So welcome to the first of a series of lectures on ultrasound for the EMET course. This is the first series that's going to talk some of the basic principles of ultrasound so that you've got an idea of what's happening and understand a little bit about the machines, but it's not going to dwell too heavily on some of what we're going to do and what are the capabilities of an ultrasound. So we're going to go a very rapid overview of things and only cover things relevant to EFAST with a touch of some things that are useful for the foundations for some of your further learning. The take home that I want from this talk is to really focus around B mode or brightness imaging. And we'll talk about how that's generated and how that shows the kind of images that you're going to be most familiar with. This works on the principles of what you would have seen in terms of sonar, so that pulse echo, so where a sound wave is sent out, reflects on a surface and then is detected back at the ship and can detect where that is and how big that is. Ultrasound is generated using crystals. These special piezoelectric crystals have a special property that when an electric current is placed across that crystal, it will change shape. And if we do this quickly, we can get those crystals to change shape really quickly and generate a sound wave. And if we do it quickly enough, we can generate a sound wave that is at the ultrasound wavelength. So typically many megahertz that we're going to be dealing with in the context of medical ultrasound. The useful cross benefit is that whilst it can generate that sound wave, it can also change it the other way around. So when sound comes back and hits the crystal, it causes it to deform and vibrate, and that will generate an electrical impulse. So not only can it create sound, but it can turn sound back into electricity. So on an oversimplified version, we'll put some electricity across this crystal, turning it on and off will make that vibrate quickly. That will generate a sound wave that moves through some tissues and reflects off a surface that comes back again and causes that transducer or crystal to vibrate, which generates an electrical impulse that goes back to the machine for interpretation. With transducers, it's the same sort of thing. So this sound wave goes off to the surface, is reflected and comes back. And if we know the variables involved in the basic equation of speed equals distance over time, we know how long it's taken for that pulse to go away from the crystal or transducer surface, be reflected and come back. We know that by inference, distance equals speed times time, and we've inferred that the speed of sound in soft tissues is at 1,540 meters per second. It'll move faster in bone and relatively slower in air. What this will do is the machine will create a screen that's reflective of the kind of sound beam that is being thrown out by your transducer itself. So in the case of a curved array, that sound wave is sent out, it's reflected and it comes back. The machine then by inference says, okay, that's the speed of sound in soft tissue. I'll generate that impulse and I can interpret that as being that far away from the transducer itself. But it's just not one crystal, it's many. So there'll typically be over 100 crystals within the surface of a transducer, all individually electrically wired, that can create their own individual pulses or can work in various different unisons to create slightly different shapes of sound waves. So they don't send it just in one direction, but in many directions, and each of those will be reflected to create an electrical dot, as we said. Sorry, my apologies. So it will create a dot on the screen at the distance that it's doing, and as you get more and more of those, you'll get more and more information. But it's even more than that. The ultrasound doesn't all hit that surface and reflect, some will pass through. So some will reflect and come back to the transducer, and another part of that ultrasound or the sound wave will continue onto the far field and will hit another surface where it's reflected, and both of these will make their way back to the transducer, and depending on how long it took to get back to the transducer, it will create a dot on the screen. Now, depending on how well that reflects, it will create a brightness in that dot. So in this circumstance, this surface doesn't reflect quite so well, so that dot will be less bright, whereas this surface is highly reflective and it's creating a very bright dot. in this circumstance. And as we get more and more information, like any pixelated image, something that is small amounts, when you get lots and lots of information, you get a readily apparent picture. And in the context of ultrasound, this is a picture of a right upper quadrant. And what we're seeing here is this is a kidney, this is your liver here, and this is the outside peritoneum with the spine towards the midline. But even better than that, it doesn't create just a static picture. When we're looking at ultrasound, what happens is it's a real-time moving image. So it'll refresh every so often. And so what you'll actually be able to see is not only see liver and kidney, and in this circumstance, we're seeing that little bit of hydronephrosis in around here in the kidney. We'll be able to see that move as the patient breathes. So it's a much more dynamic assessment of what's happening in your patients than some static image that you would otherwise get with chest x-rays or CT. When we're describing these images, it's worthwhile knowing some of the basic terminology. In ultrasound, we describe things that are very, very white as echogenic. This is hypoechoic with respect to this, and this is anechoic. And that would be the way we'd typically describe things. Echogenic structures are things like bone, stones, and air. And this is when the ultrasound crosses interfaces of changing impedance. And that's typically at these episodes. Things that are very, very similar in terms of the impedance to tissues and show very, very little impedance to the passage of ultrasound are relatively anechoic. And this will be things like fluid, blood, urine effusions would be typically the sort of things that you're going to see that are almost black. For completeness, we'll touch briefly on some of the other modes and why we have them and the features within ultrasound. But sometimes it can get a little bit overwhelming, but we'll try and work our way through it fairly quickly. In our standard ultrasound 2D brightness mode imaging, we send multiple beams across multiple different directions, each being reflected to come back to create multiple different dots across our screen that then get interpreted and reflected on the screen multiple different times. When tissues are moving relatively slowly like this, we can see them move. But when they pass a certain threshold, they can merge, and it can be very, very difficult to see fast moving structures with 2D B mode imaging. And that's when we convert to using M mode, so motion mode imaging. And instead of trying to create pixels across the entire screen, we change it to a single line of sight. Looking down the single line of sight, we're looking at a moving structure which will be moving up and down with respect to the transducer. So as that moves up and down, you can imagine the kind of image that that would create if it was going so fast. On our standard B mode, it's just going to create blur, and we're going to see this smudged dot that we really don't know what the nature of that is. But in M mode, we'll move the x-axis, so the horizontal axis will move with time. And so instead of just seeing this upward blur, as this structure moves within that, we can see that reflection moving up and down related to that. And because it refreshes so quickly, it can resolve things at a very, very high velocity. And this is what we'd typically see if we looked on the cardiac imaging. The machine will typically give you a 2D B mode reference image. You look down a single line of sight, and down that single line of sight you can see the motion of the anterior mitral valve leaflet, and you can just about see the posterior leaflet in this circumstance. We can see things like the intraventricular septum, and we can see how that contracts during systole and relaxes during diastole. And so you can see how the very, very rapid movement of that flickering mitral valve during atrial contractions and then the active relaxation of the ventricle, you can see different patterns of movement of that valve. Mostly we use it for patterns of movement, but it was used in the past when the ability to store large amounts of data was less so on ultrasounds. Now it's using, so it was to show a static image of something that's actually moving. Whereas now most of the time we'll just take a clip and we'll look at that. For most of our point of care imaging, a lot of what we achieve can be achieved with just standard B mode imaging. For completeness, this is actually a lung ultrasound, and when people were recording M mode across a lung, because of the relatively rapid movement of the lung up and down on these small irregularities, tiny imperfections in the surface of the pleural create this disruption to the sound wave at this level. And what happens is, instead of it being reflected uniformly as occurs in the soft tissues, it then gets a little bit scattered. And what it's been likened to is the sea in a sandy beach. So this is the seashore sign, versus when there's a pneumothorax, the air just reflects evenly at this tissue and reverberates. And all we see is this endless series of evenly spaced things, rather than seeing that visceral pleura on top of the lung. And so we see this series of straight lines here, and this is likened to a barcode or a stratosphere sign. Other modes that we can use are again to do with flow. There can be colour, power Doppler, pulsed wave Doppler, continuous wave, and in more advanced machines, tissue Doppler. There are some really much more advanced, like 3D imaging, speckle tracking, that is completely beyond the scope of what you're going to do at point of care. The principles for most flow imaging uses Doppler. So if you've heard a motorcycle approaching you and then going away from you, you'll notice a change in pitch of the engine. It'll be higher pitched as it moves towards you, and it'll be lower pitches as you move away. This principle is employed with ultrasound. So when it's ultrasounding something fast moving like blood, that flow will cause a shift in the frequency of that ultrasound when it's detected compared to when it was sent out, and that'll be detected as a Doppler shift. When we're doing colour Doppler, flow that goes upwards towards the transducer will be typically appearing red, and if it's flowing down away from the transducer, it'll be typically blue. So flow upwards towards the transducer, red, blue if it was travelling away from the transducer, not unfortunately to depict arteries and veins. So principles of blue away, red towards being the acronym for the BART principle. This is just a video clip of a tachycardic patient with significant mitral regurgitation, and what we're seeing is this predominantly blue flow as it flows regurgentantly through the mitral valve, which is up here, and that's going blue away from the transducer because the transducer surface is here. So predominant flow this way you'll see as blue, and as it swirls in that atrium, what you're seeing is that red flow coming up towards the transducer this way. So blue away and the red towards us of that regurgitant jet. With spectral Doppler, this is looking at more precise flow rates within valves, not whether it's occurring or not, but how fast it's occurring on a actual scale. On the left, we've got pulsed wave Doppler, which has got a hollow fill because it's got a specific range that we're looking at. Whereas the difference with continuous wave Doppler, it looks at every flow rate that occurs along this. And typically, if you're looking at things with high flow rates, it'll typically be outside of the envelope that you're interested in. So high flow rates can be traced this way. Whereas if you're looking at flows at a specific range, you'll have the pulsed wave with a hollow infill. The challenge of pulsed wave, one might argue you'd use it all the time, but the problem is that at high flow rates, it can't resolve it, and you get a problem of a thing called aliasing. And in that circumstance, we need to convert to continuous wave. Now, if this is getting all too much and painful, don't worry so much. Go back to B mode. There is no substitute for getting good B mode imaging. You'll get most of your answers with this, and that's after many years of imaging. I still would use the B mode for the vast majority of the clinical answers that I'm trying to achieve. You're often faced with a large range of transducers, but for the purposes of what we're doing, we're going to keep it very simple. We're going to look at curved array transducers here. We'll touch briefly on some of the other transducers, but for the most part, we won't be wanting or have any desire to go through cavity transducers in this circumstance. The type of picture and shape of the ultrasound screen that you're going to see with a phased array, it's going to be because this is a very, very narrow beam at the start of it that's spraying out in all directions to get through the narrow gap between ribs here and here. Whereas on an abdominal array transducer or a curved array transducer, the footprint's much larger. It means that you get better resolution of the pictures that you see, but this won't fit readily between ribs. Sometimes we'll go across a series of rib spaces though, and we'll use this for lung ultrasound because it probably achieves the best balance of being able to see the ribs and the gap in between. Then we're looking at musculoskeletal applications. We'll use higher frequency transducers and linear array transducers to get the best possible resolution within tissues. To remember what kind of transducers and frequencies you need to choose, I tend to use the comparison between Pavarotti and a choir boy. So Pavarotti will have a lot more power in his voice and will be lower pitch, so lower frequency. But you can imagine he's going to be able to get through a lot of tissues, or you can imagine it the other way, that if someone's of the body habits of Pavarotti, you're going to need a lower frequency. Whereas something you want high resolution and doesn't have to travel very far or deep, then you're going to be choosing the higher pitch of the choir boy, so the high frequency. When you're holding the transducer, it's much, much better to hold it delicately between your fingers, a little bit likened like a pencil, so that you can do very fine movements, as windows are sometimes a little bit challenging, and you can do that. Holding it between the palm of your hand in a club-like grip will clearly achieve big things, but not with any finesse, so a club grip's not to be encouraged. Just as your crystals in the surface of the transducer, you should imagine them like your mother's fine crystal. And this is the sort of thing you would have the good grace to take care of, understanding that if you drop crystal, it'll shatter. And unfortunately, that equates to not insignificant amounts of money, sometimes upwards of $15,000 for a replacement transducer. Imaging planes. Within CT imaging, you'll be familiar with sagittal, coronal and axial planes. But in ultrasound, whilst we talk a little bit about it, we, by convention, would use the transducer marker to be able to orientate ourselves. When you look at the transducer, typically on one side there'll be a bump or a ridge or something that creates a marker that you can equate to. And what this marker equates to is this part of the screen. So if this transducer was looking in this way, the marker will be the upper side. So that's that there, as opposed to. So on the body, if we were scanning, for instance, the left upper quadrant and had this kind of screen, what this would have is your marker you would have by convention on this side, which equates to this. And as time gets on, you'll understand that that equates to effectively this kind of picture to orientate yourself, which means that this is going to be your spleen, this is lateral, this is medial, these are the vertebrae, and this is your kidney. So kidney, more superficially, you're going to see your spleen. This is going to be your skin out here, as this equates to the image. By convention, we'll typically have the marker to the patient's right, so your left, when you're scanning in the transverse plane, and when you're in the vertical plane, be it sagittal or coronal, we'll typically keep that marker up towards the head. So in summary, for image generation, we talked predominantly around B mode imaging and brightness mode. We talked about some of the transducer types and how you're going to typically use the curved array for the majority of your work. We've reminded ourselves about imaging planes and how to use the marker towards your head or the patient's right side. And we said to hold the transducer typically with a fine motor grip as opposed to a gross motor grip. In the next talk, we're going to talk a little bit about the machine controls so that you're able to optimize and adjust your imaging itself.